to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Kris Kowdley, Director of the Liver Institute Northwest and Professor at Elson Floyd College of Medicine, Washington State University. Welcome to episode 1 of 2 of clinical clips from the 2024 EASL Congress titled Key Breakthroughs in the Treatment of Primary Biliary Cholangitis. The first abstract we're going to be discussing is the effect of elafibranor on pruritus and primary biliary cholangitis, symptom severity, and quality of life measurements from the phase 3 ELATIVE trial. So pruritus is a commonly reported symptom of PBC that often negatively impacts quality of life. The 5D itch and the PBC-40 are patient-reported outcome measures that capture both the severity of pruritus and, importantly, the impact on patients' quality of life, although only the PBC-40 is a validated disease-specific instrument. The phase 3 ELATIVE trial showed that elafibranor did not significantly reduce moderate to severe pruritus according to the PBC Worst Itch Numeric Rating Scale, also called the Worst Itch NRS. By contrast, the seladelpar study, which was also a phase 3 trial of PBC, did show a statistically significant improvement in Worst Itch NRS in treated patients compared to placebo. However, in the elafibranor trial, the ELATIVE trial, we found improvements in pruritus were observed with the 5D itch and the PBC-40 itch measures. So the objective of this study was to further explore the effect of elafibranor on pruritus as measured by 5D itch and PBC-40 week 52 in the ELATIVE trial. So the 5D itch and PBC-40 questionnaires were recorded at each study visit in ELATIVE. 5D itch has 5 domains with scores for each ranging from 1 to 5, for a total score of 5, no pruritus, to 25, most severe. PBC-40 has 6 domains, including a PBC-40 itch domain, consisting of 3 items for a total score of 0 to 15, and changes from baseline to week 52 in 5D itch and PBC-40 in the intent to treat population and in patients with moderate to severe pruritus were reported in this abstract in a poster. So of 161 randomized patients, 41% had moderate to severe pruritus at baseline. Baseline characteristics of patients with moderate to severe pruritus were balanced between those receiving treatment and placebo. Patients receiving elafibranor had greater reductions at week 52 in 5D itch total score compared to those receiving placebo in both the ITT or intent to treat population and in patients with moderate to severe pruritus. The conclusion of this study by the authors was although the PBC Worst Itch NRS assesses the severity of pruritus, the 5D itch and PBC-40 questionnaires additionally assess the impact on patients' quality of life. And in this study, treatment with elafibranor resulted in improvements in 5D itch and clinically meaningful improvements in PBC-40 itch, emphasizing the potential for elafibranor to reduce severity of pruritus. Similar observations were noted in the seladelpar study as well in the phase 3 study that was reported in the New England Journal of Medicine. And there are some differences and similarities with regard to 5D itch and PBC-40 measures in the treated population. So in conclusion, it's important for us as clinicians to know that pruritus is a significant issue for patients, and the introduction of these new therapies may in fact be associated with either stabilization or, even better yet, improvement of pruritus. And we should be looking at pruritus in a global manner, both in terms of a simple instrument like the Worst Itch NRS, but also looking at 5D itch and PBC-40 that specifically evaluate the impact of pruritus on quality of life. Our next abstract is titled Long-Term Efficacy and Safety of Open-Label Seladelpar Treatment in Patients with Primary Biliary Cholangitis. Interim results for 2 years from the ASSURE study presented by Dr. Palak Trivedi from University of Birmingham. So ASSURE is open to patients with PBC who have participated in previous seladelpar studies. There was a phase 2 dose-ranging open-label study with 2, 5, or 10 milligrams, and then patients were entered into a phase 3 long-term safety study. The phase 3 enhanced study was a placebo-controlled trial with 5 or 10 milligrams that was intended to go for 12 months, but was stopped at 3 months. In addition, patients entered the phase 1b hepatic impairment study, which was open label for less than 30 days. And then finally, patients from the phase 3 response pivotal placebo-controlled trial of 10 milligrams of seladelpar versus placebo comprised the study population titled Legacy Studies. And these patients then entered the phase 3 ASSURE open label study of 10 milligrams. So the total number of patients in the study was 337, and it included 179 patients from legacy studies, as well as patients from the response study. So patients with insufficient response or intolerance to first-line PBC treatment with ursodeoxycholic acid or participation in a seladelpar clinical trial could enroll in ASSURE. Key endpoints were the composite biochemical response, defined as an alkaline phosphatase reduction to less than 1.67 times upper limit of normal, with a decrease of at least 15%, and a total bilirubin of less than upper limit of normal. Alkaline phosphatase normalization was also assessed in this study. Pruritus was reported using a numeric rating scale, and baseline for participants who entered ASSURE from response was entry to response, analyzed as continuous seladelpar or crossover from placebo. Legacy patients, as I mentioned, were analyzed separately with baseline set as the entry to ASSURE. So as of January 31st, 2024, 158 patients from the response trial and 179 patients from legacy studies had received 10 milligrams of seladelpar daily for up to 155 weeks in ASSURE. In response, 61.7% of patients treated with seladelpar met the composite endpoint at month 12 versus 20% of patients for placebo. With continued treatment in ASSURE, 61.8% at 6 months in ASSURE and 72.4% at 12 months in ASSURE met this composite endpoint. Among placebo patients crossing over to seladelpar, 75% at 6 months and almost 94% at 12 months met the composite endpoints. Furthermore, alkaline phosphatase normalized in 25% of seladelpar-treated patients and 0 of placebo patients at month 12 in response. With continued treatment, 33.3% and 17.2% at 6 months and 12 months respectively achieved alkaline phosphatase normalization. For crossover patients, 27% and 50% had alkaline phosphatase normalizations at these time points respectively. The change in pruritus NRS with seladelpar in ASSURE was similar to response, with a minus 3.8 and minus 3.7 change from baseline at 6 months in continuous and crossover patients respectively, corresponding to the key secondary endpoint in response. Among legacy patients who had previously been in other trials, 73.2% and 69.7% met the composite endpoint at month 12 and month 24 in ASSURE. Normalization of alkaline phosphatase was achieved by 42% at 12 months and 42.4% at 24 months, and reduction in pruritus NRS in this group was minus 3.8 at month 12 and minus 3.1 at month 24. The safety profile was favorable with no treatment-related serious side effects. So the authors concluded that continuous treatment with seladelpar for response in legacy patients led to sustained effects on biochemical markers and pruritus, and seladelpar appeared safe and well-tolerated with long-term use. My comments on this abstract and why I think it is an important one is it demonstrates, first, the safety of long-term therapy with seladelpar, which is an important consideration given that we expect patients to be on therapy, if not indefinitely, at least for a prolonged period. And also that with continued therapy, we don't see a loss of response, but in fact, an accumulation of patients who achieve the composite endpoint and even more importantly, from my perspective, a substantial proportion of patients achieving alkaline phosphatase normalization. The next abstract I will review is combined effect of obeticholic acid and bezafibrate in patients with primary biliary cholangitis and inadequate response or intolerance to ursodeoxycholic acid, 6-month results from a phase 2 trial. And this study was presented by Dr. David Jones and co-authors from Newcastle University and other centers. So obeticholic acid is currently approved to treat PBC as second-line therapy. Obeticholic acid is effective in about 47 to 48% of patients in reducing alkaline phosphatase to less than 1.67 times upper limit of normal, with a 15% reduction and maintaining a normal bilirubin. And these are the so-called POISE criteria. Obeticholic acid is associated with the side effect of pruritus, which can be dose-related, particularly earlier in therapy, and this is a limitation of its therapeutic use. Obeticholic acid is also associated with relatively low rates of alkaline phosphatase normalization. Bezafibrate is a fibrate that is widely used in other countries, not available in the US, to treat PBC, and has a favorable effect on lipids and is associated with improvement in pruritus. So the idea of using these two agents in combination would be to achieve greater levels of alkaline phosphatase reduction and possibly mitigate pruritus and lipid changes that may occur with obeticholic acid. So the study was a randomized, double-blind, active-controlled phase 2 trial where patients were randomized 1:1:1 to either bezafibrate alone in an immediate release preparation, bezafibrate in a sustained release preparation, and obeticholic acid titrated from 5 to 10 with a low-dose bezafibrate, or obeticholic acid titrated from 5 to 10 milligrams with higher dose bezafibrate. There was a 12-week double-blind treatment period and then a 12-week open-label long-term safety extension. Percentage change from baseline and normalization rate of alkaline phosphatase, total bilirubin of less than 0.6 times upper limit of normal were assessed. Biochemical remission was defined as normalization or a greater than 40% reduction in ALP, with gamma GT, ALT, and AST being less than upper limit of normal. GLOBE and UK PBC scores were assessed, and safety was assessed by treatment-emergent adverse events. So 75 patients enrolled in the double-blind treatment period. 66 continued to the open-label safety extension. At 6 months, OCA with 400 of bezafibrate sustained release showed a 65% reduction in alkaline phosphatase and a 27.6% reduction in total bilirubin. Approximately 61% of patients in this cohort achieved a normal alkaline phosphatase, and 83% achieved a bilirubin less than 0.6 times upper limit of normal. The OCA bezafibrate 400 combination induced biochemical remission in 67% of patients, and 78% of these patients experienced a greater than 40% reduction in ALP from baseline. The OCA bezafibrate 400 group achieved the greatest change in GLOBE score and UK PBC scores, which are prognostic scores predicting long-term risk of liver-related adverse events. Treatment-emergent adverse events were generally balanced among the cohorts. One patient in the OCA bezafibrate group, 400 bezafibrate group, discontinued due to a serious treatment-emergent adverse event of pruritus. The rate of new events of pruritus with the combination therapy was low at 11% at 6 months. The combination therapy also demonstrated the greatest percentage reduction in total cholesterol and LDL cholesterol. The authors concluded that these results suggested that OCA and bezafibrate was generally well tolerated and has a therapeutic potential to normalize multiple serum biomarkers associated with improved transplant-free and decompensation-free survival. They also observed lower rates of pruritus with this combination therapy than historically was observed in the phase 3 POISE OCA trial. These data suggest that, in fact, the combination of OCA and bezafibrate in this proof of concept study confirmed the hypothesis that adding bezafibrate to OCA may reduce pruritus as a side effect, along with mitigation of adverse lipid changes, and may achieve much higher rates of biochemical normalization of alkaline phosphatase and other liver biomarkers than has previously been observed with monotherapy, and support further development of this combination as a therapeutic option for patients with PBC in need of second-line therapy. The next abstract we'll be reviewing is titled Efficacy of Elafibranor in Primary Biliary Cholangitis, Results from the Variable Double-Blind Period of Elative, a randomized placebo-controlled phase 3 trial. This study was presented by Dr. Kris Kowdley on behalf of co-authors from University of California, Davis, and other sites. PBC is a rare autoimmune cholestatic liver disease characterized by the destruction of interlobular bile ducts, resulting in cholestasis and liver fibrosis. Elafibranor is a dual peroxisomal proliferator activated receptor PPAR alpha delta agonist, which significantly improved prognostic biomarkers of cholestasis at week 52 in patients with PBC in the phase 3 ELATIVE trial. Previous reported safety data up to 104 weeks have suggested that elafibranor is safe and well tolerated. The goal of this study was to evaluate the biochemical efficacy of elafibranor in patients with PBC beyond week 52 in the ELATIVE trial. So in ELATIVE, patients who met the usual criteria for entry into PBC trials were randomized 2-to-1 to elafibranor, 80 milligrams or placebo once daily for at least 52 weeks. Patients then continued their assigned regimen after 52 weeks until all patients had completed the week 52 visit, or for a minimum of 104 weeks, whichever came first. Efficacy outcomes beyond week 52 in the variable double-blind period were reported in this abstract by the authors with a focus on week 78. The biochemical response assessed was the primary endpoint that included alkaline phosphatase less than 1.67 times ULN, with at least a 15% reduction from baseline, and total bilirubin less than ULN. At week 52, 51% of patients on elafibranor achieved a biochemical response, compared to 4% receiving placebo. At week 78, 70% of patients receiving elafibranor achieved a biochemical response, compared with none of the patients, 0 of 13, receiving placebo. 21% of patients receiving elafibranor who achieved biochemical response at week 78 had not achieved response by week 52, and 79% of patients had a sustained response from week 52. Furthermore, at week 52, when 15% of patients, 16 of 108, receiving elafibranor achieved alkaline phosphatase normalization, compared to no patient receiving placebo, ALK-Phos normalization occurred at week 78 in 5 of 27 patients, or 19%, compared with no patients receiving placebo, 0 of 13. Based on these results, the authors concluded that following the previously reported efficacy outcomes, biochemical response, alkaline phosphatase normalization, and changes in liver-related biochemical parameters were sustained or improved with elafibranor through 78 weeks of treatment in patients treated in the ELATIVE trial. Aside from the biochemical efficacy, the effect on the impact on pruritus has already been reported. The main limitation of the study is relatively low patient numbers who were included in the beyond 52-week cohort, which were impacted by the study design. But based on these observations, it is possible to conclude that a subset of patients who are treated beyond 52 weeks, who may not have achieved biochemical response criteria, may respond with continued therapy. And certainly we know from URSO treatment and other treatments that have been studied in PBC that the higher the alkaline phosphatase when a patient begins therapy, the longer it may take to achieve improvement in alkaline phosphatase to the desired level on treatment. And certainly in clinical practice, we don't stop therapy or decide about efficacy or futility after 52 weeks alone, and support the rationale that continued therapy may be associated with greater improvement in biochemical response criteria than with a discrete threshold at which we decide a patient is a non-responder. Long-term studies in the open label safety extension arm are currently underway for elafibranor and for seladelpar, which we have described in previous abstracts, and will help answer the question of increased rates of biochemical response with prolonged therapy, and of course, collect very important data on safety, tolerability, and treatment-emergent adverse events. Thank you for joining us for episode 1. Please refer to the landing page for slides and to claim your continuing education credit. And please be sure to come back tomorrow for our final second episode from the 2024 EASL Congress. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.